Okay, so a very good evening to all of you. This is part 2 on lichen planus. We have already covered what is lichen planus. It is a chronic mucocutaneous disease. The etiology is CD8 plus T cells which target your basal keratinocytes and cause apoptosis. And then we have seen the skin lesions, which were the 4 Ps. They were pruritic, polygonal, purple, papules. In this video, we are going to talk about the oral manifestations, the histological features, malignant transformation of these, and the treatment. So getting right into it, before that, you can check out more videos on the channel to be told under the playlist Oral Pathology. So getting into the oral manifestations, OLP classically has 6 clinical presentations, which is the reticular, papular, plaque, atrophic, bullous, and erosive form. Looking at the reticular form, this is the most common and readily recognized form of lichen planus. It is characterized by white lines or striae, right? So you have white elevated lines or striae, which may be in the form of lace or a network pattern, or it may be in the form of rings, like so. So here you have rings, and here you have a network-like pattern. They often display a peripheral erythematous zone and are located bilaterally in the buccal mucosa. So the most common site of occurrence is the buccal mucosa bilaterally, the mucosal side of lips and the vermilion border. The papular type is the representative of the initial phase of the disease. There are elevated white dots that are present on the keratinized surface of the mucosa, and they intermingle with the reticular form. So here you have white elevated dots, and in the left corner, they are intermingling with the reticular white striae. Right, so they represent the initial phase of the disease. The next is the plaque type, where you see a homogeneous, well demarcated white plaque. So in this diagram, you have a homogeneous white plaque in association with the reticular form. Clinically, it resembles your leukoplakia, but the difference is that in oral lichen planus, it is multifocal in distribution and it is associated with the reticular form. This form is most commonly encountered in smokers. Now, the 3 forms that we have discussed so far, which is reticular, papular, and plaque, these forms are associated with asymptomatic lesions. So the person does not have any complaints except a feeling of roughness. In the next 3 forms, the patient has burning sensation or pain associated. So starting with the erythematous or the atrophic form, it is characterized by a poorly defined homogeneous red area. So in this diagram, you can see a red area which is diffuse in its outline. There are striae at the periphery. Very clearly, you can make out there is a diffuse red area with striae in the periphery. When it is associated with the attached gingiva, it is called desquamative gingivitis. So here in this diagram, you have the marginal gingiva, and then you have the attached gingiva where you see a diffuse redness. It is not associated with any striae. Here, the patient also complains of a burning sensation with food intake. Okay, so it is a diffuse red area which may be seen on the attached gingiva also, which is called desquamative gingivitis with burning sensation. The next form is the bullous form, which is a rare or an unusual form where you have bullae or vesicles. Bullae or vesicles are fluid-filled elevated lesions on the skin that range from a few to centimeter, and they often ulcerate, leaving a painful eroded area resembling the erosive or the ulcerative form. So you have bullae here, which are elevated blisters. Often they rupture, giving rise to the ulcerative form. So the ulcerative form is nothing but the form of oral lichen planus, which is the most disabling and painful. Here the person has irregular ulcers coated with fibrin. So here you can see there is an irregular ulcer which is coated by fibrin with striae in the periphery. it is raw, painful, and the most disabling form. The oral manifestations may occur weeks or months before the appearance of skin lesions, and other mucous membranes affected are the penis, vagina, and epiglottis. Up to 25% females show the involvement of genital areas. So again, revising, we have seen the three asymptomatic forms, which are reticular, which may be lace or annular. Then we have seen papular, plaque, and then we have seen the symptomatic forms, which are atrophic, bullous, and erosive lichen planus. Moving on to the histopathology, this is very simple. Now, the histological findings of lichen planus are very simple because it is very easy to remember it. Why? Because it affects all the layers of the epithelium and subepithelium, right? So it affects epithelium as well as subepithelium. Starting with the first layer, here we have hyperkeratosis. Okay, so the first point is hyperkeratosis in the form of hyperparakeratosis or hyperorthokeratosis. In the second layer, you see the spinous layer. The spinous layer shows acanthosis or thickening with intracellular edema. So there is thickening of the spinous layer. When you go below that, you see degeneration of the basal keratinocytes with cytoid bodies, right? So these are hyaline cytoid bodies, which are called the civat bodies. So the first point is hyperkeratosis, the second is acanthosis of spinous layer, and the third is degeneration of basal keratinocytes with civat bodies. The fourth point is that the retiredges are sawtooth in shape. Instead of the normal retiredges, these retiredges are sawtooth shaped. And the fifth point is that there is weakening of the epithelial connective tissue interface leading into Max Joseph spaces. So here you have the epithelium and here you have the connective tissue. There is weakening of the epithelial connective tissue interface leading to Max Joseph spaces, which are nothing but histological clefts. The final point is band-like subepithelial mononuclear infiltrate. So subepithelial means below the epithelium, you have a heavy band of inflammatory infiltrate. And this inflammatory infiltrate is composed of T cells and histiocytes. So again, I will remind you the histological features. The first is hyperkeratosis, the second is acanthosis of spinous layer, the third is degeneration of basal keratinocytes with civat bodies, the fifth is sawtooth retiredges, the sixth is Max Joseph spaces or histological clefts, and the seventh is subepithelial band of inflammatory infiltrate. The direct immunofluorescence results a positive fluorescence in the basal membrane zone with extensions into the lamina propria. The malignant transformation is 0.3 to 3% highest in the erosive form, right? The ulcerative form shows the highest malignant transformation and it is considered a pre-malignant lesion. The treatment, there is no cure, but the main aim of the treatment is to resolve the symptoms. The symptoms are the lesions that you see, the pain that is associated, the oral hygiene that is compromised, and the malignant transformation. The main outline of the treatment involves the use of corticosteroids, which are topical or systemic. There is antifungal therapy in case of candida lesions, adjunctive retinoid treatment, immunosuppressive treatment, and the removal of any irritating factor. So before we conclude, I have a few review questions for you. Name the types of oral lichen planus. Out of that, which is the most common clinical type and which is the pre-malignant type? All of the following are histological features of lichen planus except sawtooth retiredges. Yes, you see them. Liquefaction, degeneration of basal keratinocytes. Yes. Max Joseph spaces. Yes. Acantholytic epithelial cells. No. Acantholytic epithelial cells are seen in pemphigus. Here you see acanthosis, which is the thickening of the spinous layer. A case-based question, a 60-year-old female presented with burning sensation to spicy food. Okay, so there is a burning sensation to spicy food. Intraoral examination revealed multiple periodontal abscess and keratotic areas in a lace pattern. So there are keratotic areas in a lace pattern. This is suggestive of the reticular form with erosive areas inside the lace pattern. So this is suggestive of the reticular plus erosive form of oral lichen planus. So the correct answer is oral lichen planus. With this, we come to the end of the video. Let us quickly revise what we have studied. We have studied the oral manifestations, which included 6 classical patterns, which were 1, the reticular. The reticular was lace-like or annular or ring-like. Then we spoke of the papular pattern with elevated white lesions, the plaque type with homogeneous white plaque, the atrophic type, which was associated with diffuse homogeneous red erythema with peripheral striae, bullous form with fluid-filled blisters, and erosive form with irregular ulcers coated by fibrin. We spoke of the histology where we saw hyperparakeratosis or hyperorthokeratosis, thickening of the spinous layer, degeneration of the basal layer, Max Joseph spaces, cytoid bodies, and subepithelial inflammatory infiltrate. We saw the direct immunofluorescence, we saw the pre-malignant erosive form, and then we saw the treatment modalities. We saw some questions, and with this we come to the end of the video. I hope this video helps you for your exams, and if it does, please do give it a thumbs up, share it with your friends, and comment the answers if you can. So with this, I hope you all have a good day ahead, and thank you so much.